afternoon, good evening to everyone who has joined our annual Commonwealth Civil Society Policy Forum from all over the Commonwealth and beyond. It is indeed a pleasure for me as the chair of the Commonwealth Health Professions and Partners Alliance to welcome you to our annual event, which sets the scene, as it were, for us to provide inputs to the Commonwealth Health Ministers meeting. Today, I'm particularly pleased that we have a large number of participants joining us from many parts of the world. And I'm also particularly pleased to see all our panelists, the speakers, and others who have joined us. I would like to, at the outset, express a special word of thanks to the Commonwealth Pharmacists Association for the leadership role they played in organizing this year's forum. The objective of this year's forum, which is conducted on the theme of actionable solutions to build resilience in healthcare systems within the Commonwealth, with an emphasis on small and vulnerable states, is to raise awareness on the impact of climate change and natural disasters on health and of current health workforce challenges across the Commonwealth, particularly in small and vulnerable states. Secondly, to create dialogue within the civil society around these challenges, share best practices, and agree on potential ways to address priorities by leveraging the Commonwealth network. And finally, to develop actionable recommendations to address these issues for presentation at the 2024 Commonwealth Health Ministers meeting, and to build resilience in healthcare systems throughout the Commonwealth. In preparation for today's forum, I would like to thank all those who responded to our survey and gave us input, because that has been valuable and we have taken note of that. So without further ado, let's move on to today's forum. And today we have eminent panelists to speak to you. But before we move to the speakers, I would like to, first of all, welcome Right Honourable Baroness Patricia Scotland, the Secretary General of the Commonwealth. The Secretary General has been a tower of strength to us over the years and has been supporting the activities of the Commonwealth Health Professions and Partners Alliance, and have been an active member, active participant in our civil society fora. Today, she is unable to be with us in person, but she has provided us with a recorded message. And let's begin by listening to her message to the Commonwealth Civil Society Forum.
Distinguished guests, ladies and gentlemen, good morning, good afternoon, and good evening to all. This is such an important moment as Commonwealth civil society comes together to develop recommendations on health systems resilience. I am currently in Tanzania for the Commonwealth Law Ministers meeting. I wish I could be with you in person, but I'm so grateful for this opportunity to join you virtually. The timing of today's session is perfect, as we are now just weeks away from the next Commonwealth Health Ministers meeting, where our shared responsibility to strengthen health system resilience in our Commonwealth becomes an opportunity. You all understand how difficult our task is. The widespread health and socioeconomic impacts of COVID-19 and other communicable diseases rising rates of non-communicable diseases and mental health conditions, climate-related health threats, aging populations, and pressure on resources all present challenges to the health and well-being of Commonwealth countries. These overlapping challenges makes our focus on resilience so important. Resilience is about our health system's ability to prevent, prepare, detect, adapt to, respond to, and recover from public health shocks whilst maintaining access to quality, essential health services. It is a key indicator of the capacity of our health systems to withstand and respond to urgent and structural challenges. The theme of Commonwealth Health Ministers is actionable solutions to building resilience in healthcare systems within the Commonwealth, with an emphasis on small and vulnerable states. Delegates will consider the increasing impacts of climate change on our health systems, the need to strengthen the capacity and capabilities of our global health and social care workforce, and our collective progress towards health-related sustainable development goals. And there is no question that their deliberations will benefit from your input. Civil society plays an indispensable role in fortifying our health systems. Civil society plays a pivotal role in shaping the trajectory of global health, serving as a catalyst for change, a watchdog for accountability, and a voice for those who are not heard. Civil society also serves as a bridge between policymakers, healthcare providers, and communities, facilitating dialogue and building trust. So I am clear, it is not possible to achieve true resilience without civil society, not only in the delivery of policies and programs, but in shaping them from the very start. And I'm eager to hear your advice about how we can work together to strengthen health system resilience across the Commonwealth. As you deliberate, I ask you to consider some essential questions about how we can confront inequity so that our progress towards universal health coverage leaves no one behind, about how we can harness the renewed momentum generated by last year's UN high-level meetings, not only on universal health coverage, but on pandemic prevention, preparedness and response, and TB, and about how we can centralize the resilience of our health systems in the common future we are all striving for, and which our heads of government will unify around at CHOGM in Samoa later this year. By investing in robust health systems which prioritize equity, inclusivity, and sustainability, we pave the way for a brighter future for generations to come, because we will be building towards a more fundamental truth that health is not merely the absence of disease, but the foundation upon which thriving societies are built. Today offers us all the opportunity to renew our commitment to a world where health is not a privilege, but a fundamental human right. Together, in health and across every sector, the extraordinary qualities and potential of our Commonwealth family means we are more than equal to the challenges we face. So I invite you to dig deep, be bold, and share your highest ambitions. And I look forward to receiving the recommendations and sharing these at the forthcoming Commonwealth Health Ministers meeting. And I thank you.
I'd like to thank the Secretary General for truly setting the scene for today's Civil Society Policy Forum. Let's now move on over to our second speaker, Dr. Anne Gallagher, the Secretary, the Director General of the Commonwealth Foundation. Anne is joining us from Tanzania. So over to you, Anne.
Thank you very much, Vajira, and hello, everyone. Vajira, you're absolutely right. I'm sending my warmest greetings from Zanzibar, where, along with the Secretary General, I'm currently attending the Commonwealth Law Ministers meeting. Just quietly, though, I'm very happy to duck out for a bit to be with you at the Civil Society Policy Forum. Participating in these discussions over the past couple of years has been incredibly enriching for me, and I'm thrilled to be part of this opening session for what I know is going to be a great event. It's wonderful to see so many people here. I think most of you know that the Foundation is the Commonwealth's intergovernmental agency for civil society. The Secretariat looks after the member states, and the Foundation looks after the 2.5 billion people, or we try to. At the core of everything that we do is our firm belief that governance, so when we talk about governance, we're talking about policy formation and decision-making in relation to everything that matters to people and their lives, must be participatory and inclusive. It must recognize civil society not just as a participant, but as a critical force for change. So this event, coinciding with the year of an important Commonwealth Heads of Government meeting in Samoa, as the Secretary General referred to, highlights the urgency and I think the timeliness of our gathering. The Foundation team will be in Samoa to deliver the 2024 People's Forum, the single largest gathering of civil society in the Commonwealth. The forum will have three main themes. Health justice is one, and climate justice is another. So we're here, I think, today to focus particularly on the Commonwealth's small and vulnerable states. So this group of countries, including our small island states, despite their beauty and I think their resilience on many fronts, face disproportionate challenges, especially from the intensifying impacts of climate change. This reality brings into sharp focus our responsibility towards these countries and communities, emphasizing the need for targeted support and action. And this is a collective Commonwealth responsibility, one that's based on a specific commitment that's enshrined in our charter, one that should shape the work of everyone connected to the Commonwealth. I'm thinking back to something that happened a few years ago, the tragic example of the Hannah Thomas Hospital in Barbuda, which closed in 2017 following severe damage from Hurricane Irma. I think this situation illustrates the fragility of healthcare infrastructure in the face of natural disasters, underscoring the importance of building resilient healthcare systems that can withstand, respond to, and recover from such crises. I think everyone here at this meeting knows what resilient healthcare systems look like. They're systems that are capable of anticipating, of preparing for, of responding to, and recovering from a wide range of internal and external crises, all the time maintaining their core functions at optimal levels. Developing and sustaining resilient healthcare systems in small and vulnerable Commonwealth countries is challenging. Often, geographical isolation limits access to essential medical supplies and expertise, while small economies and limited resources constrain the capacity of these countries to invest in necessary healthcare infrastructure. And as the pandemic showed so starkly, All too often, it's the smallest and the most remote who just get left behind. The historical lack of investment in health infrastructure, coupled with the migration of healthcare professionals seeking better opportunities abroad, has left many of our smaller states with healthcare systems that are under-resourced, overburdened, and ill-prepared to handle the dual challenge of emerging health crises and the impact of climate change. To be truly resilient, healthcare systems in small and vulnerable Commonwealth countries must be supported to overcome the interconnected challenges that are threatening their communities. And this leads us to the big questions. How can the healthcare systems respond, for example, when waterborne illnesses increase after flooding, reducing access to clean drinking water? How can healthcare providers, already short on equipment and resources, manage an outbreak of infectious disease when the shipment of necessary vaccines is hundreds and sometimes thousands of miles away? Last year, at the Commonwealth Health Ministers meeting in Geneva, the Foundation presented 12 key asks for progressing towards universal health coverage. These were not generated by us. They were developed with insight from over 300 civil society practitioners and professionals from across the Commonwealth. These asks are foundational to our discussion today, highlighting essential strategies for reinforcing healthcare resilience, especially for small island states. So I just want to spotlight 3 of these. The first of these is around healthcare system design. Designing healthcare systems that can withstand and adapt to climate change is non-negotiable. In order to build these kinds of healthcare systems, we need to act quickly and decisively. Small island communities in particular, bearing the brunt of climate impacts, need systems that are both robust and anticipatory. This means crafting policies and enhancing infrastructure to withstand climate challenges, while at the same time empowering health workers with the skills they need to manage this health-climate nexus effectively. By adopting an evidence-based approach, we can create a healthcare ecosystem that is explicitly designed to protect our most vulnerable populations from the storms of climate change. The second key ask was around engaging communities in healthcare planning. I think, again, everyone at this meeting knows that community engagement around healthcare planning is critical. By fostering partnerships that allow for genuine co-creation of health services, we make sure that our efforts are grounded in the realities and needs of those we aim to serve, enhancing the system's responsiveness and resilience. Third and finally, or at least for the 3 key asks that I'm highlighting, we need to look at healthcare resilience as a global issue with global solutions. We need to collaborate and to cooperate to achieve global solidarity. The challenges we face are not confined by our borders, even if they're being unevenly felt. Our solutions, therefore, must be global in their reach and perspective. By fostering a spirit of collaboration between countries and by involving all sectors of society, government, civil society sector, we stand the best chance to share knowledge, technology, and resources that are essential for strengthening healthcare systems in our smallest and most vulnerable country. This global collective action is the cornerstone of building healthcare systems that can withstand the challenges of today and of tomorrow. And I see this meeting, I see the breadth and the profile of the participants in this meeting as embodying exactly what we need at the global level. So as we move forward, let's embody in our own work the principles of innovation, inclusivity, and cooperation. Our shared journey towards building more resilient healthcare systems in the Commonwealth's smallest and most vulnerable countries is not just a testament to our collective will, but a necessity, an absolute necessity for ensuring a healthier and more equitable future for all Commonwealth peoples and nations. So thank you very much for your commitment and your leadership and for joining in this vital conversation. I look forward very much to the insights and progress that will emerge from our discussions. And I also look forward to seeing at least some of you at the Health Ministers meeting in May and at CHOGM in October. Thank you so much.
Thank you, Anne, for really putting all of us on the spot and, reminding all of us the challenge that we all have to rise up to. Thank you very much for your comments, as well as all the support that the Foundation is giving us to have our civil society policy forums, as well as other activities. Thank you very much. Now, ladies and gentlemen, let's move over to the our speakers. So we have three eminent speakers today. And the first speaker is Sir Colin Tukitunga. He is a public health medicine specialist from New Zealand. He's going to talk to us on the impact of climate change on health in small and vulnerable states. Sir Colin is unable to be with us in person, and therefore he has sent us a recorded talk. We'd like to play that for you now.
Greetings from New Zealand. It's a pleasure to speak with you all. I was asked to speak on the impacts of the climate crisis on health. So I have a few slides that I will share with you. This first slide is actually a picture taken at the Bethio maternity ward in Kiribati. This is during one of the king tides, and as you can see, the waves are crashing over the fence, and imagine mums having a baby with this sort of scenario. I understand that they're moving to new place, but this is one example of a healthcare facility severely impacted by the climate crisis. So in the short time that I have, I just want to talk a little bit about the Pacific, the climate crisis, of impacts of the climate crisis on small island states, health impacts of the climate crisis, comment about infrastructure and the islands. The first thing to say, of course, is the Pacific Ocean is the largest ecosystem on the planet. It supplies 2/3 of the global tuna supply that goes into your sandwiches. And it's a source of 80% of the protein for Pacific communities, approximately 10 or more than 10 million people, mostly in Papua New Guinea, Fiji, Solomons, and Vanuatu, a very young population, mean age of 21. And the people in the Pacific are a bit grumpy with the rest of the world because they've been custodians of the ocean over many years. And these days, of course, it's being threatened by pollution, by overfishing, by illegal, unregulated fishing, environmental degradation, and habitat destruction. So the climate crisis in the Pacific Islands is the most important threat to lives and livelihood. It's an issue of social justice here. Small islands contribute less than 0.03% of the harmful greenhouse gases, but they are the ones that are severely impacted by the climate crisis. Many of these communities, of course, live close to the coast. 90% of them live close to the coast, and many of them have been forced to move because of climate change. The other thing to say is that I regard the climate crisis as a multiplier, meaning it just makes worse what's already there. So, for example, access to clean water in the islands is a problem for many islands, and the climate crisis will just make that worse and more difficult for people. When we talk about climate change, people get excited about this sort of picture, dramatic floods and cyclones and severe weather events. And it is important, no doubt. The region's Pacific Islands face several cyclones every year from November through to April. But the big issues associated with the climate crisis, of course, are sea level rise, and in particular, ocean acidification and ocean warming, which leads to coral bleaching. And coral bleaching threatens the food chain. And you'll recall me saying that Pacific communities get most of their protein from the sea. And of course, one of the things that happen with the climate crisis is their water sources get contaminated. And the other thing to say is that even the higher islands, like my own home in Niue, was severely damaged by Cyclone Heta in 2004, and it's a pretty high island. So islands are impacted by the climate crisis, whether it's low-lying atolls or high islands. So on the one hand, sometimes you have flooding in some islands and droughts in others. A whole list of impacts, food security, impact on water security, erosion and loss of land, loss of their economic base, biodiversity loss, threats on economies, as well as direct impact on health. And the climate crisis, of course, affects pretty much all of the so-called determinants of health: food we eat, the water we drink, the weather we experience. And as I mentioned earlier on, climate change, the climate crisis is in effect multiplier. And so, of course, our advice to small island states in the region have been to be as prepared as they possibly can. Food security is a major concern. Predictions of coastal fisheries harvest declining by half due to overfishing, pollution, ocean acidification, and fish migration moving further away out east. And sea level rise, of course, will have impacts on particularly low-lying atolls through loss of land, erosion, saltwater intrusion. One of the things that this is a fairly old slide, but it's a fairly representative of the threat of arboviral infection spread around the region, particularly dengue fever. And it's now all 4 types are circulating in the region. There was a recent WHO SBC study of hospital facilities in 14 of the small island states in the Pacific, and clearly demonstrating the vulnerability of these facilities. Many of them are located near rivers or near coastlines, and which means that nearly 2/3 of the total population are at risk of losing their healthcare facility, especially at a time when there's severe weather events. I showed you a slide of Besio Hospital in Kiribati, located 5 meters from the coastline and not very high. Similarly, in the Solomon Islands, the National Referral Hospital is 11 meters from the coastline and a mere 2-meter elevation, putting at risk the referral hospital for 700,000 people. The Pan American Health Organization Smart Hospital Framework is one tool that's been promoted for countries as they try to modernize and update their facilities to make them less vulnerable to the climate crisis. So just to finish off, the climate crisis is a real and existential threat to Pacific communities. Minuscule contributions to the harmful greenhouse gases, but among the most severely impacted by the climate crisis. It affects food supply, water supply, air, habitats, healthcare facilities. And the climate crisis, of course, makes worse things that are already there. And one of the things that the island leaders have been pushing has been to encourage the rest of the world to honor and implement the agreement agreed in Paris in 2015. So a quick overview. So thank you very much.
Thank you very much to Sir Colin for that overview of the situation that is, facing us. And I think what he highlighted there, especially the issues related to where, healthcare facilities are located. And that is something that sometimes those of us living in even the larger countries cannot appreciate. I think the vulnerability of those healthcare facilities, which are just on the coastline, as it were. Thank you very much. So let's move on to our next speaker. Our next speaker is Dr. Nirmal Kandal, the Head of Evidence and Analytics for Health Security at the World Health Organization. Is going to talk to us about strengthening health emergency capabilities. Over to you, Nirmal.
Thank you, Wazira. I think slide will be shared from that side. So before I start, I would like to start with the one story because we have a civil society group and pharmacists and a lot of public health specialists here. So in 2015, I was the emergency team lead in WHO Indonesia office. During that time, I was deployed to Nepal's earthquake in 2015, and one of the highly affected districts where half of the mortality was from that district. And what we have noticed is the engagement of community health volunteers during the earthquake response as well as recovery has actually increased the resiliency in the community and society. So I don't know whether you are aware of community health volunteers. There are actually a bridge between the public and the healthcare service delivery mechanism or systems. But what I also noticed is that during that earthquake, because many losses, not only houses and properties, but also their near and dearest one as well. And this group, the female community health volunteers, they are the one who are providing even psychological support, because traditionally, anybody who has a mental health issue, people will not come up front because it's stigmatized. It's part of the cultural practices, and these female community health volunteers are the bridge, even for recovering from the post-traumatic mental health issues as well. So why I'm reflecting this is that it requires community engagement to have a community resilient. When we have a community resilient, then the national system will be resilient, and the global system as well. And this is where we need to invest on the health workers, especially on community health workers. And COVID-19 is also another example where the community health workers exist. These countries manage pretty well on responding to the COVID-19 events. So with this small story from my experience, I would like to request to move the slide to the next one, please. And the story that I said actually published in the Lancet also. And after the presentation, I can share the link as well. So based on the COVID-19 and other emergencies, so WHO is now putting an effort on strengthening health emergency prevention, preparedness, response, and resilience architecture, which builds on the three main variables. One is governance, second on financing, and third in systems. So the one which I'm presenting on the slide is more on the systems, which builds on the on what we call 5 Cs. It's collaborative surveillance, access to countermeasures, safe and scalable care, and community protection, as well as emergency coordination. Next slide, please. And these are based on the existing practices that guided by the International Health Regulation. And I don't know how many of you are aware that we have a IHR monitoring and evaluation framework to look at the IHR capacity or health security capacities at the country level. I'll not go into detail, but we built on these frameworks in supporting countries to strengthen their capabilities for health emergencies. So why I brought it here is previously the benchmark, which I'm going to talk in next few slides. We can move to the next one. In the past, we used to call IHR benchmark. So it was published in 2019. And then based on all the events, we updated, and we are now calling it WHO benchmark for strengthening health emergency capacities. So let me first start. What is this? It's a list of benchmarks that are required to sustain IHR and then emergency prevention, preparedness, response, and resilience capacities. A list of actions that can increase these capacities to strengthen the emergency capabilities. It is informed by technical experts, and it's a starting point for development of a technically sound plan for health security or other emergency capacities also. And just I would like to highlight that it is aligned with the updated M&E tools. It also updated with the architecture that I mentioned earlier. It captured all the lessons learned from recent health emergencies, and it also focused on those health system foundational elements that are required for the health security and emergency. Just to add one more, that we also have now disaster risk reduction related benchmarks as well, which I will share in a slide in a couple of minutes. Next slide, please. So I want to brief you on the updating process, because we carried out a very rigorous updating process. It took almost 3 years with 2 online global consultation and 1 face-to-face meeting in Geneva last year. More than 250 technical experts across the world, within and outside of WHO, who contributed. And now we have like 80 benchmarks, which has each benchmark has a list of suggested actions that country needs to implement in order to achieve the sustainable capacity for health emergencies. Because this document is almost 400 pages, and it's very difficult to navigate. And I think this is one of the few documents that come up with the portal for easy navigation. I'll give some example on the portal as well in the next slide. Next slide, please. So what are the technical areas that we are looking? I'll not go into detail, but we have captured many technical areas which are not initially captured by the IHR as well. And with the emergency architecture we have captured. I would like to highlight 3 or 4 things here. Our opening welcome address, Secretary General mentioned that about the equity, and now we have a gender-related benchmark to mainstream gender in health security or health emergency, from preparedness to response to recovery. And the example that I put forward, female community healthcare workers, actually the first responder and first responder, as well as contributing to the recovery as well. Second thing which I would like to mention here is we have a dedicated area of community protection, where in more emphasis on the community engagement, risk communication, infodemic management, and this is where the civil society has a major role in order to improve the resiliency of every community. And the third thing which I will highlight that is the disaster risk reduction related benchmark. I will go into detail in the next few slides, but this also applies. This can help countries, especially those fragile, small, and vulnerable setting, which we call FCVs countries, to support on strengthening their capabilities and improving their resiliency. Next slide, please. So I'll show you how these benchmark actions will be useful for developing the actions and moving forward. So I took an example of human resource. So these are there are four benchmark areas, and each benchmark is categorized from level 1 to 5 because it has aligned with the existing monitoring evaluation tool like state parties annual report, joint external evaluations. So when countries are in level 2, if they want to move to level 3 and 4, there's a list of suggested action. Why we need these is because when the countries have assessment or evaluation, it is countries find difficult to translate that recommendations to activities and actions. So this benchmark actions provide those list of suggested actions so country can use it while developing the plan. There are a lot of opportunity benefit of this document, which I'll share at the end. So these four benchmarks also capture the role of community and the community health workers during emergency, before, during, and after emergency as well. Next slide, please. So next, it's a disaster risk related benchmarks mostly, and it has there are additional benchmark also in this on this category of emergency management. But basically, we have now four benchmarks, which is directly linked to the disaster risk reduction, and this is first time we have updated, and countries which are planning to develop the disaster related plans for the emergencies, especially for the health sectors, it can support as well. Just to let you know, if you notice there is a color difference, white and other color, because we have highlighted in the benchmark document what are the actions that requires the other sectors contributions. So this benchmark also identifies what are those actions that needs support from other sectors. If you look at the disaster, there's a role of home ministry and security authorities, and these are captured there so that it will help countries to bring other sectors on a planning process, because plan is not everything. The process is important where the roles and responsibilities are delineated. Next slide, please. So first we use it as a planning tool, but when we start implementing it and disseminating it, it has a lot of opportunity benefit also. So we are now using this as a framework for our health security capacities, for prevention, detection, and response for public health risk, as well as the prevention, preparedness, response, and resilience. It is a planning tool for the various planning processes. In the portal, I will also explain that there are disease-specific actions also, so it can generate the automated draft disease-specific plan also. We are also using it for tool to check the progress of implementation of the recommendations and actions. So for instance, the pandemic fund, many countries who have received the pandemic fund grant, we are going to use the benchmark as a checklist to see the progress over the period of time, because it's very difficult to change the capacity level with a 20% within 3 years. So this will be used also. It is also a reference guide which can generate evidence, and we are also using for the operational implementation research. This can guide on developing the recommendations for countries for any kind of evaluations, and it can guide to develop strategies and prioritizations. Many donors and partners are using it to develop their work plans to support the countries, for instance, Resolve, CDC, World Bank. And it also helps on prioritizing the resources required for the health security, emergency, and IHR. And it is also aligned with the global framework, a regional framework that exists. And as I mentioned, the portal also have a disease-specific plans, and also the portal will have a capability to generate operational readiness plan as well in a couple of months' time. Next slide, please. So I'll briefly touch upon how this online portal works, and the link is available there, and you can play around with this portal, because the 400 pages document navigating each and every area is very difficult. So with the portal, it makes easy, and you can go to the area of interest of the technical area that you have an interest, and use it also. So basically, it brings the existing score of in order to develop the plan, you can use the state parties annual report score or the joint external evaluation, and then you can set the target, and it can generate the draft plan, which you can develop, which you can take it to the technical consultation with the relevant technical group also. You can also include the disease-specific plans if you would like to. So we have right now respiratory pathogens, especially for the influenza or COVID-19 type of things. We have for the cholera and Ebola, but we will be expanding with other threats as well. Next slide, please. So when you select the country, you automatically the target will be there, but you can change that target. If the country is in level 2 and wants to move in 3 years to level, instead of 3 to 4, they can amend it. One beautiful part of the portal is that when we are developing the plans, there are a lot of duplications in different technical areas, and this portal has a algorithm behind which can detect where are the number of consultation, so you can reduce that number of consultation. There are a lot of training, you can combine those trainings, so in order to improve the efficiency also. Next slide, please. One other thing is it's easy to say what to do, but how to do is another challenge. So we have this portal with the reference library. So each benchmark areas, each actions are linked with the references, either guideline, templates, tool, or the training packages. So country can use when they are implementing those actions, and they can adopt or adapt these guidelines and tools. So in one place, you can have those things accessible. And next slide, it's my last slide. So one thing I would like to take the opportunity as part of the resilience, we have a framework called Health System for Health Security. And this is the framework guides that we need to have a foundational health system elements in place in order to ensure the health security, not only the epidemics or pandemics, but also other events. So when there is a disaster or when there is an earthquake, the biggest challenge is to manage the outbreak of the respiratory infections or the diarrheal outbreak in those settings when there's a big disaster happen. And this is where we need we need to make sure that foundational elements of health system are in place. And I often give an example that you cannot strengthen infection prevention and control during emergency. It needs to be in place as part of the routine healthcare systems, from primary healthcare to tertiary healthcare. So this framework brings all the health security related capacities and identify those foundational elements from the health system, as well as the involvement of other sectors. We have a fantastic IPC in a hospital, but however, infection prevention control system in place in hospital, but the water supply and sanitation system is not well, then our IPC will be compromised. When these things are in place, we can ensure that there's a improved health security, the health system become resilient and responsive, which will ensure social and financial protections and improved efficiency as well for the healthier population. And last slide is briefly about the thanking you all for listening to me, but also the links are available, the various work that we are doing. And one thing I would like to mention before handing back floor to Vazira is we need a lot of case studies that are done in fragile and small countries. So if you have any documented evidence, please share with us in that email. We would like to use to put it in the reference library, as well as use for developing our strategic tool when we are updating them. So with that note, back to you, Vazira, and thank you for inviting us.
Thank you.
Forum.
Thank you very much, Dr. Nirmal. I was, fascinated by the amount of work that WHO is doing in this area, and this is definitely an area to which we've not been previously, introduced to. So I'm particularly pleased that you were able to take the time and share this with us, because I think for all of us in professional association, health professions organizations, I think there's a lot to digest there. And also, it also tells us that there is a lot of ways in which we can, engage the WHO. And the last point that you made about case studies, I think that is definitely an area where we can collaborate with WHO to, showcase case studies where our membership is, familiar with. And I think there may be good practices that they would be able to share with you that will definitely be of value in various places around the world. So thank you very much for taking the time to be with us today. We value your contribution, Dr. Nirmal. Thank you. Let's now then move over to the third talk, which is going to be done by two speakers. Michelle Thompson from the Global NHS Senior Workforce Lead. She is the Global NHS Senior Workforce Lead. And then Laura Felicia, who is the Praxis Education Lead. And she's at the Leeds Teaching Hospital NHS Trust. So I will hand over the mic to both of you, and they are going to talk on putting education at the heart of ethical recruitment, a case study from St. Vincent and Grenadines and Leeds Teaching Hospital NHS Trust. This is an area which is which all of us are interested in, because mass migration from low middle income Commonwealth countries is threatening health systems across the world. And we are all we've been all discussing this wherever we go in the Commonwealth today. This is the hot topic, as it were, for healthcare leaders, because maintaining our health systems in the face of migration has become a serious threat to all of us. So over to both of you.
Great, thank you, Vijay, for those introductory words, and lovely to be here today at the Commonwealth Civil Society Policy Forum. It's actually my first visit to the forum, but I hope it will be not my last. I'm actually here representing Professor Jed Byrne, who is the Director of Global Health at NHS England. He unfortunately can't be with us today, but he has shared a small video which we're going to start with, and then Laura and myself will take you on to our presentation. So hopefully with technology will allow us to share that video now. So let's give that a few minutes to start.
Jed Byrne. I am the Director of Global Health at NHS England. I'm really sorry that I can't be with you today. A conversation that I was really looking forward to having, but unfortunately I'm on my way back from Gibraltar. But Vicky and the Commonwealth Pharmacists Association and myself have been working together for many years now, looking to develop and implement solutions to some of the real problems that are facing the delivery of healthcare over the course of the next decade or so. So just by way of introduction and thinking about those issues, I guess there are 4 specific areas that we need to think about that are likely to impact us progressively over the next generation. And these are planetary health and the changes in planetary health will bring to the delivery of healthcare, global health security, and the lessons that we have learned or otherwise from the recent COVID-19 pandemic, the increasing migration of healthcare workforce, both good and bad, across the planet, and the associated workforce gaps. And then the final thing is the increasing importance of equality, diversity, and inclusion within our multi-professional and multicultural high-quality workforces. I think that Vicky and I agree very strongly that the way forward for this, particularly from an NHS perspective, is through the development of robust and sustainable partnerships. And what we mean by partnerships are those that occur between governments, those that occur between places, those that occur between institutions, and those that occur between people. I think it is extremely important that over the course of the next few years, we lay down partnerships on those 4 levels between different countries to allow sustainable health service transformation to solve or to help solve those 4 issues that I mentioned. Once again, really sorry that I can't be with you today, and I hope you have a wonderful time, and I'm really looking forward to seeing the output of the discussions.
Thank you. A few key words there from Professor Jed Byrne. So as I mentioned, I'm going to start the presentation. There'll be some slides on the screen. These will be shared with you afterwards. I'll give an overview of our work, a bit of background to what the Global Health Unit does, and then hand over to Laura, who's going to talk to you about a really co-developed and key partnership between these teaching hospitals and the Government of St Vincent and the Grenadines. So I'm Michelle Thompson, Senior Workforce Lead here in the Global Exchange Health Unit at NHS England. I've been in the NHS now for a long period of time. I actually came for a 6-week summer job back when I was a lot younger than what I am now, and that has continued up to the present time, and hopefully will continue for a long time to come. I've worked in global health for about the past 10 years, and from my work in a large acute hospital in the North England, I became really interested in developing global partnerships, as Jed mentioned, either between governments or higher education institutes, other healthcare providers, and that's really been part of my journey, both personally and professionally, for the past number of years. And I hope what I'm going to show you today will be something that you'll take away elements of, and hopefully, perhaps areas that you want to get involved in. We can explore and hopefully co-develop some future projects around workforce and education development. So please do reach out to myself, Laura. I've also got Andrew here as well. Our project manager is on the call as well, and we'll share our email addresses so that you can contact us afterwards if it's something, if there's elements that you feel you might be able to, we can explore working together in the future. That would be great. Could I have the next slide, please? Thank you. So a little bit about what we do here in the Global Health Unit. So we're a small team, there's about 35 of us, and we work with NHS partners and overseas organisations to support them in developing strategic and bespoke global approaches to healthcare workforce. And we build relationships which strengthen health systems, both here in the NHS and overseas. And the approach that we've taken is very much around collaboration and mutual benefit for all. And our ultimate aim is really to improve patient care by strengthening, diversifying, educating and training the health workforce, both here in the NHS and overseas. So as you can see on the screen, we've got 3 global priorities, and we work at 3 levels. The first one is that we work at individual levels. So that's through improving the availability and quality of global learning opportunities for staff working in healthcare, through programmes such as observership programmes and fellowships, and that's in both directions of travel. We also work at system level, so that's through development of globalised workforce solutions such as ethical migratory pathways, partnerships between NHS organisations and overseas healthcare organisations and governments. And then the third area that we focus on is very much through global health system strengthening. So that's focused on opportunities to collaborate with NHS partners on shared challenges to strengthen the healthcare system. So those are our 3 key areas that we focus on. Could I have the next slide, please? Thank you. We do work on very niche and bespoke ethical migratory pathways, and those programmes support recruitment, working directly with overseas governments, but only where there is a surplus of staff. And that's very much in conjunction with the World Health Organization Code of Conduct. And it's we're very much working in partnership both with NHS organisations and overseas governments to really link up and join together to really put healthcare workers at the heart of what we do here. This is not about large-scale international recruitment, but very niche pathways which focus on in-country education and ongoing education once individuals arrive in the NHS to prepare them for working here in the clinical environment. As I say, though, it's very niche, it's very small, it's very bespoke, and it very much links and joins up with the WHO Code of Conduct. We don't work with countries where there isn't a surplus of healthcare workers or there is an identified shortage. It's, as I say, it's very much focused on that supply, that pathway that we can see may be available. And just moving on to the next slide, you can see in this fan diagram examples of the range of ethical migratory pathways that we've developed. I think traditionally the focus has been on nursing recruitment, but we've really been able to work closely with higher education institutes and overseas governments really to broaden those pathways and really look at developing opportunities where they may exist. The next slide, please. So moving beyond that, one area I really want to focus today, and I hope this is something that people will take away and perhaps want to explore working with us further, is we've developed a number of managed education partnerships, and I'm really pleased to say that a number of these have been with Commonwealth countries. And these have been developed by the global team at NHS England, and they support healthcare workforce development, bringing together NHS partners and overseas healthcare systems. So these partnerships are very much co-developed. They're linked to health system strategic priorities and goals, and they very much focus on sustainable outcomes and very much around strengthening of the workforce, both here in the NHS and overseas. So next slide, please. One area that Laura's going to talk today about, but I'll just touch on it briefly, is the real success story of a managed education partnership. And it's a case study that's been developed between ourselves here at NHS England, Leeds Teaching Hospitals and the government of St Vincent and the Grenadines. It did start off as a small, very bespoke ethical migratory pathway to support a group of unemployed SVG nurses gain employment in the NHS, and it was very much led by the Ministry of Health and the High Commissioner from St Vincent and the Grenadines to the UK, Mr Lewis. It's since then developed and it's really broadened out into a number of key initiatives. So we've run a talent programme for nurses, both at Leeds and in St Vincent and the Grenadines, which is around developing future leaders through an online learning platform. We also, I'll come on to talk about this in a little bit more detail shortly. We also run the National Global Health Fellowship Programme, and that's opportunities for employees from Leeds Teaching Hospitals to spend 6 months in St Vincent and the Grenadines working on quality improvement programmes. Laura will talk in lots of detail around the Clinical Observership Programme, which is a real fantastic opportunity and one that we really would like to broaden out to other professions and other partners as well. And that's an opportunity for clinical staff to spend an observership period of time at the hospital trust. And as you can see on the screen, there's a real wide-ranging benefit to stakeholders, both here in St Vincent and the Grenadines and at the trust. Next slide, please. So moving on, one area that we do also lead and develop is the NHS Global Fellowship Programme. It's a national fellowship programme for NHS staff to spend typically up to 6 to 12 months working overseas on quality improvement programmes. I mean, it's been running for the past 15 years and over 350 staff have taken up this opportunity to go overseas and broaden their knowledge through experiencing and working in different healthcare environments. Just moving on to the next slide, you can see there the countries and global partners who are involved. So pleased to say some of those are Commonwealth countries, but as ever, we are looking to reach out to new partner sites. So if from this presentation today you are interested in finding out more about opportunities, particularly around fellowships or developing a managed education partnership, then please do get in touch. Very much here to look and work together on health workforce solutions. And just finally, I thought I'd end my presentation really before I hand over to Laura with a quote from the Honourable Prime Minister of St Vincent and the Grenadines, talking about the managed education partnership between NHS England and Leeds Teaching Hospitals, bringing in, you know, what we've heard about from previous speakers today, you know, around climate change and the many health challenges that Jed also spoke about in his video as well, and really around the importance of building effective partnerships. So on the final slide, if we could move on, please, just onto my contact details as well on the next slide as well. If anybody does want to reach out, I've put my email address on there. Please do get in touch. I'm more than happy to arrange follow-up meetings or calls to explore opportunities. We're really very keen to broaden our work programme and work with countries across the Commonwealth. So I'll stop there and hand over to my colleague Laura, who's going to talk about her role and the case study at Leeds Teaching Hospitals. But thank you again for the opportunity to be with you all today.
Thank you very much, Michelle. So hello, my name is Laura Fletcher. I'm one of the lead for the professional development teams at Leeds Teaching Hospital. So as you've heard, I am a therapy radiographer as background, but I've been involved in the multi-professional education arena for quite many years. And recently, for the last couple of years, I've been involved in the ethical recruitment, education and pastoral support of our workforce at Leeds Teaching Hospital. Can we move on to the next slide, please? Thank you. So we're just going to give you a little bit of an overview for Leeds Teaching Hospital. So we are one of the largest teaching hospitals in Europe. We're in the north of England, in the United Kingdom. We've got expertise from 7 hospitals over 5 sites. We've got a wealth of clinical experience and offer many learning opportunities. We're linked in with many institutes, local, national and worldwide, to offer many learning opportunities in education. Our aim is to be the best for specialists in integrated care and to be the best place to work. We employ over 20,000 staff and we treat an average about 1.6 million patients each year. So we've got a large footprint and a large thing. So we can move on to the next slide. So this is just a diagraphic overview of our hostel, of the different hostels that we have. So Leeds as a city has got about 800,000 people within the city. So we're a massive city within a massive region of the north of England. On to the next slide, please. So how have we got involved with NHS England Global Unit and part of St Vincent's and Grenadines? So our relationship started pre-pandemic with St Vincent's and Grenadines and NHS England, where we agreed there was an oversupply of unemployed nurses at St Vincent's and Grenadines, and we had a depleted nursing workforce at Leeds Teaching Hospital. So we went into partnership to ethically recruit and employ 35 nurses. They joined our team in 2021. However, we know that the pandemic changed the landscape of healthcare workers and they were in demand absolutely everywhere. So the partnership, even though it's sustainable, because we had some great relationships and fostered some really good working environments, but we changed from recruitment to being more resilient and supportive practice with St Vincent's and Grenadines, to have some workforce transformation work that was going on, where this would benefit both the healthcare economies that they would learn from us and we would learn from them. It's a win-win situation. We've got very similar healthcare structures as well, so it was quite a good partnership to go in. We formed a tri-partnership with NHS England and the St Vincent's and Grenadines Ministry of Health. And it was a new programme that we created, that we co-created. Nobody had partnered this, and we didn't know what we were going to do, and we didn't know what we were going to develop. So we co-created it together. It was very interesting. It was very important that we had to learn from each other and we had to develop this together. Just before we developed the programme, I think NHS England Global Unit had gone in and they'd helped St Vincent's and Grenadines understand what priority areas they wanted to cover and to do. And we came out with 5, which we'll show you in later slides, 5 priority areas that we were going to work on and do. So on to the next slide, please. So what our offer was, this is a very, very, very quick overview of what our offer was, because I could talk about this for hours and I'm very conscious about the time that we've got. So what we offered was, us at Leeds Teaching Hospital, we would organise the flights, the accommodation, the welcome packages, make sure that the nurses that were coming over were orientated into Leeds. So we hosted 5 nurses from St Vincent's and Grenadines to come over. They were coming over on an observership, and the reason they came over to an observership is just due to visa restrictions and professional regulations within the UK. There was no hands-on care was allowed to give. So it was more of an observership. Come and learn, come and talk to us, come and see what's on offer here. Is there any initiatives or any healthcare pathways that can be taken back into St Vincent's and Grenadines? But also, is there any healthcare initiatives or any ideas that we could take on within the NHS, within Leeds Teaching Hostel as well, to learn? So it was an 8-week placement. So week 1, very conscious that people were coming across from 12-hour flight, jet lagged, very excited. There's lots of emotions, anxieties and excitements as well, but also very mindful that St Vincent's and Grenadines is a small country made up of many islands, and they're coming across into Leeds, which is a very dense and populous city. So we wanted to settle into Leeds, give her an orientation. It's not all work. We wanted some play and some fun to have as well, and some experiences that were there. We made a bit of a fuss. We welcomed, and we had a celebration that comes in. So there's a pride of pictures. We've got a pathway of arriving very tired on the bus to the excitement, into meeting everybody and into the end. So then we went on to the placements for weeks 2 to 8. So those placements were in older adults, critical care, mental health, and we also hosted the Chief Nursing Officer as well. So created a Chief Nursing Officer placement as well that was there. So there's objectives that were worked. We were understanding that we had to co-create this. We didn't know what we didn't know, and the nurses that were coming over didn't know what they didn't know. So it's very much a flexible, bespoke placement based on themes that people wanted to do and wanted to see. Go on to the next slide, please. Also very mindful that people were coming across, and the clinical practice is also very important, but we also had to have some of the soft skills that were coming across. What can we offer? We've got with the NHS Leadership Academy, and we've got a very good reputation at Leeds Teaching Hospital for our leadership development and our communication and our coaching development. So we created sort of 9 bespoke programs for people: motivational interviewing, how we can speak to patients and change behaviours. With coaching, which is very much into the leadership and interaction of it all. And one important workshop actually that is the power of the patient voice. At Leeds Teaching Hostel, we have patients that are absolutely in every single quality improvement and continuous improvement we get involved in. We have the patient voice. And we realised that St Vincent's and Grenadines, just with conversations, had patient feedback, but didn't use it for continuous improvement. So we helped them experience the family and friends and create that they could take back and implement into their projects and stuff that was going on. And also we are partnered with the Virginia Mason Improvement Academy. So we trained in the Leeds improvement training just to make sure that we had lean and continuous improvement and quality improvement in everything that we did. Can you move on to the next slide, please? So the mutual benefits. What are the mutual benefits of having these partnerships and these managed educational partnership? Well, actually, there's a wealth of experience and a wealth of evidence out there to say that it's for staff morale, and it increases job satisfaction, and that is both for the country that we're hosting and for the people and for the country that is visiting. People want to be involved in these. You feel special, you feel valued, you want to retain your staff. It's something that you absolutely would love to do. There's a mutual knowledge exchange. Mutual knowledge exchange, professional discussions is absolutely invaluable. We learn from different experiences. We learn from everything else. We're a massive transactional healthcare economy now with a massive diverse workforce. We learn from everybody. There's collaborations. We foster strong relationships. The relationships with the 5 nurses that have come across, they're still ongoing on an informal basis, but we talk through email, we talk through WhatsApp, we ask questions, we ask ideas. That is just invaluable, connecting those relationships that are there. We've also got a cultural understanding. As I said, we're very much a transatlantic transactional workforce that move about different countries. Gone are the days where somebody stays in a job for the next 20 years. We're all moving countries and moving into different roles. So it's actually embracing that amazing global workforce that's out there and learning from each other. We're also managing resources. Us in the NHS, we could be quite wasteful for where things were. And our biggest learning curve was like, yeah, we're really wasteful. We're wasting a lot of money on certain things that we potentially don't need to have. And it's the quality improvement projects that were implemented. I think naively, I thought for 8 weeks there'd be 1 or 2 ideas that'd be able to be implemented back into St Vincent's and Grenadines. And the girls that came over absolutely blew me away with the amount of projects and the ideas that they absolutely took back. And especially for the staff on the wards at Leeds Teaching Hospital, the amount of ideas they got. I've got, oh, that'll be really good to implement. They've had some really good ideas. It was absolutely amazing that it's still continuing, that's going on. And from that, we've grown a relationship. We're creating community of practices now, very much from the COVID pandemic, using the virtual environments that very much have been created and very much is allowing us to have these meetings just now. We've got fellowships that we've got staff at Leeds Teaching Hospital that are going out to help develop some of the healthcare pathways, but also get ideas to develop our pathways out here, that we send fellows out there to have an amazing time in the Caribbean. And we're having the ongoing relationships are just amazing. In 3 weeks' time, we've got another 5 nurses that are coming to visit us to start this journey again, which is absolutely fantastic to be asked to do it again. For the next slide, please. However, with projects, there are challenges.
I request you to wind. Laura?
Hi.
Vajira here. May I request you to wind up because you're 5 minutes over time.
That's absolutely fine. Yep, so we can see the challenges. The biggest one was the weather, so we've thingied that. So I'll let you read those, guys, and more than happy for people to contact me to understand. And I'll just finish on the last slide, which is just pictures for you guys to look at, and that's me done. Thank you so much.
Thank you, Laura. I think both Laura and Michelle, it's wonderful to see this, because I think there are lots of people who would like to, reach out to you and to see how we can, promote ethical recruitment, because currently, because of mass migration, lots of health systems are really facing challenges. So thank you. The fact that you have a program like this, I think should be welcome news to a lot of people who are on this webinar today at the forum. Thank you. So let me now hand you over to Victoria Rutter. Vicky is the CEO of the Commonwealth Pharmacists Association. And as I said at the beginning, Vicky is the one who put the entire forum together, together with her colleagues at the CPA this year. Over to you, Vicky, to lead the panel discussion.
Thanks for that introduction, Vajira. I think we're all quite excited now and wanting to book our flights to the Caribbean. So thank you, Laura and Michelle. But I think it's really important to sort of illustrate some of these case studies of really good practice in terms of shared learning. And the Commonwealth is really of a great network for us to investigate how we could extend some of this. So I think it's really exciting. I want to pick up some of those points in our panel discussion now. So thank you to all of our speakers, and thank you for Dr. Kandel and for Laura for staying on for this part of the programme. I know, Michelle, you've got to run off, but thank you for everything you've done for us so far. So as part of the panel discussion now, we're also going to be joined with some healthcare practitioners from around the Commonwealth, and we really want to hear from them because they're at the grassroots of what we do, and it's so important to get their views for us to pass on to health ministers. So can I have the next slide, please, Chamika? Great, thank you. So I want to introduce you now to Dr. Colin Abel, a chief surgeon from Bustamante Hospital for Children in Jamaica, Miss Annie Kurian, social work practitioner from Sri Lanka, and Mr. William Mipute, president of the Pharmaceutical Society of Malawi. Could you all turn your videos on now for me so that we can see you? That would be great, thank you. So to the audience, if you have any questions for the panel, please do use the chat box and we'll try and get around to answering some of these after the main discussions. I just wanted to add a thank you to all of those that have responded to the survey consultation around the recommendations that will be taken forward to the Commonwealth Health Ministers from this forum. And thank you also to our speakers today for their expert guidance on these. The final recommendations will be presented at the close of today's proceeding. I'd like to refocus now on the theme of the forum, which is actionable solutions to building resilience in healthcare systems within the Commonwealth, with an emphasis on small and vulnerable states. And climate change is obviously having a huge impact on our Commonwealth, and particularly on small and vulnerable states, as we heard from Sir Colin Tikutonga earlier today. And this requires health policies to acknowledge this ongoing challenge in terms of the effects on health, widening inequities, and the impact of climate change related migration on our workforce. We're clearly also seeing a greater number of climate-related events and a need to strengthen our health emergency capabilities. So climate change is an influencing factor across many of our recommendations, and clearly a priority that needs to be resourced so as to educate, adapt, and mitigate the effects. In order to address climate change and strengthen health emergency capabilities, it's essential to build a strong, resilient health workforce. More than half of our recommendations focus on this topic, and we believe it is such an urgent and critical issue that needs to be addressed. And this is where I'd like to focus our discussions with our panel now, with a particular emphasis of hearing from our healthcare practitioners on the ground. So just to frame this discussion, the key issues we're hearing around workforce based on your feedback are, firstly, there's limitations in the data available in order to understand the breadth and detail of the problem. There are not enough health workers globally, but we're also aware that for some countries, there are not enough jobs for some of those that are trained. Secondly, there are several push and pull factors regarding retention in country, such as working conditions, pay, career opportunities, etc. And these factors apply to both lower middle income countries and high income countries in different ways, and they have a knock-on effect globally. Thirdly, a huge issue continues to be migration and unethical international recruitment, made more prevalent because of the push and pull factors that are not addressed. And finally, to address the global shortfall in health workforce, there is also room for further optimisation of the way care is delivered through the use of innovative systems and technologies to support task shifting and task sharing, maximising and capitalising on the capability and distribution of health and care workers. Alongside this, we also need to look to local communities for collaboration and resourcing, including increasing health literacy, healthy living, and the ability to self-care. And I think, Dr. Nelmal, you really touched on this in your example in Nepal with the healthcare workers in their response to a disaster scenario. So I now want to turn to our panel. And I'd first like to give the panel a chance to discuss the challenge of workforce retention. And we know that the challenges are multifaceted, but in your opinion, what are the root causes contributing to workforce attrition and burnout among health workers in your region or country? And how do these challenges manifest in day-to-day practice? For example, what implications do they have for patient care? And I'd like to pose this question first to Colin, followed by Annie. So Colin, could I hear from you on this question?
Good day, everyone. Well, in the Caribbean region, we do have a problem with healthcare practitioners' retention because of salaries. So you'll find that each year recruiters from the UK, from Canada, and the United States will come into our region to attract not only individual practitioners, be they doctors, nurses, physiotherapists, and radiographers, but they'll also do packages for their families so that you can take your entire family along, and that's been a challenge for us. So presently, just to use Jamaica as an example, we only have about 60% of the nursing cadre that we need for the island. And where our doctors and specialists especially are concerned, we probably are running about the same. So that basically is our issue, salaries, and also the fact that due to the fact that our training is similar to what is expected of those persons in UK, Canada, and North America, they come and they will take our staff.
Thank you. That's really insightful, Colin. And I wonder if, Annie, you've got a response on that. And is the situation similar in Sri Lanka, or are there some differences? Annie, I think you need to unmute your microphone. Did you get that? Oh, here we go.
Yes, sorry about it. As far as Sri Lanka is concerned, we have a universal free healthcare system. And also due to the many issues that the country is going through, we cannot just put everything on the climate change related issues, but it's larger. And it had been building up the COVID pandemic and thereafter several other issues. But the final scenario on the health stuff, I would like to refer to not just the medical professionals, but also the non-medical. It's really giving an impetus for them for quite a number of people to migrate the country. So that is a big issue. But also in the meantime, our healthcare system has also gone through a lot of changes, and the capacities are dwindling in terms of institutional care, in terms of the health professionals. Then also issues like, for instance, now who are in the medical teams, the members of the medical teams. For instance, now, although social workers are there, it's not so prominent that the role that the social workers play. So there is a kind of a disillusionment on the various categories of the health teams. Then apart from that, also in Sri Lanka, I think maybe it's all over the world, the health sector predominantly makes up a larger percentage of women in the health services. And something that is really an issue is also that the care services for the caregivers. In the sense, what I'm trying to say is that the majority of the people are in the younger ages, and so therefore they will have the burden of childcare, elder care, the disability care, and our country as a whole have not developed the capacity for that. Nor is there a proper system to build the capacities of the caregiving service for those. Like, for instance, to give an example, the daycare centers, things like that. So as a result, the disillusionment and the stress that the health workers face are real. So apart from that, of course, the other issue is the discrepancies. As Dr. Collins pointed out, the pay discrepancies and various other perks. So those are all issues that add up to disillusionment. Of course, the medical professionals, they have an edge, and also the health the nurses, they have an edge over others to migrate. So there's a greater issue of those leaving the country. And my other issue is also the focus on the community level groups who have done so much service to the healthcare system. So there's not much focus to build the capacities of that kind of categories. So I think these I see as some of the key areas that I could share.
Thanks, Annie. That's really insightful. And when we were recording Colin's presentation earlier this week, he was talking about the situation in the Pacific Islands as well, where there's a big migration of health workers out of the Pacific Islands, but predominantly men, because the women tend to stay. So I do think I'm hearing stuff here about, you know, how can we perhaps sort of support the workforce that's left, and, you know, the other responsibilities that they seem to have on their plate as well seems to be quite significant. But yeah, I think that's a really interesting point that you raised there. William, I'd like to move over to you. William's joining us from Malawi. So from your perspective, how could task shifting and task sharing and the use of innovation and technology and engagement of the wider community help to alleviate some of the pressures on health services and ensure timely access to medicines and healthcare, particularly in relation to vulnerable populations? So William, I'm keen to hear from you.
Good afternoon, everyone else. Yeah, I think I should start commenting on the idea of use of technology and innovation. It's very important to capitalize on existing technologies and even advise on developing new technologies that will help in advancing health service delivery in vulnerable populations. For example, currently in Malawi, we are using drones to deliver medicines and emergency medicines in hard-to-reach areas, thanks to the efforts by Village Reach and governments. It has been shown that there has been improved access to these emergency medications and also collection of lab samples from lower sites to the testing sites at the district hospitals or central hospitals. Another comment is on community engagement. I think during the pandemic is one of the areas where we saw that it's very important that we cannot fight any pandemic without the involvement of the wider community. So as already discussed by the presenters earlier on, there's need to engage the community. It helps in ownership of the health services. It also makes it easy when we are health education, because sometimes the community will understand when the message is coming from the community leaders and not only when it is coming from us healthcare workers, because in fighting disinformation and also misinformation, community engagement is very key, and also in trying to influence health-seeking behaviors, because sometimes it's not that people don't have access to the health facility, but that they are not willing to go to the health facility for other reasons, including culture and other beliefs. I'll finish on task shifting. It has been also important in settings like ours, where we have low numbers of medical doctors, registered nurses, and pharmacists. For example, we have less than 1,000 pharmacists against a population of approximately 20 million people. So you can imagine the gap that is there. However, with the help of pharmacy technicians and pharmacy assistants, we have been able to reach out to some people. And in other cases, our task has been shifted to people that we call health surveillance assistants, mainly that they have MSc as qualification, which is higher education here, not graduate program. However, the challenge now comes in when we have now trained the required personnel to take up the tasks that were previously assigned to people that were not properly qualified, just to suit, just to ensure that services are going on. Sometimes it becomes a challenge. So in task shifting, there should be a clear cutoff point to say that when now the numbers of the qualified people are in the system, they should be slowly getting back to what they should do, so that we shouldn't compromise quality in the process. Thank you.
Thanks, William. That's a really that's really insightful. I'm just wanting to pick up on that last point regarding the quality, and what do you think the risks are in terms of, you know, obviously we're trying to run services and we have to rely on what we've got available, but by allowing people to run services, is there a risk that the qualified cadre of health professionals will not be integrated into the health systems in the future?
Thank you so much. So we have seen it already in our setting that it is a threat where when now the qualified people are becoming to fill the system, there is resistance from the people that were simply assigned the tasks in the absence of the qualified people. They feel like now they own the task, but then the quality of the service is not as it should have been if the tasks were being handled by the qualified and the rightly trained personnel.
Gosh, that's really interesting. I think there's a lot of things here that we could follow up in further webinars, but I think I need to move on to the next question for this forum. So I wanted to kind of move on to now the ethical recruitment side of things. So obviously there's a long history of high income countries engaging in poor international recruitment processes and practices. And Colin, you've kind of talked about that just in this forum. So this has led to the development of the WHO Code and previously published Commonwealth Code on international healthcare worker recruitment. So we're now hearing examples of where attempts are being made to test and implement ethical recruitment approaches. And we've heard a case study today from St Vincent and the Grenadines, and thank you to Michelle and Laura from this. So to my panel, from your perspective as a healthcare worker striving to deliver the best patient care for your communities, do you think bilateral approaches like the ones Michelle and Laura have shared today could be a mutually beneficial way to address some of this health worker migration and shortages? And what potential challenges do you foresee in this? Annie, I wanted to ask you to kick off with that one.
Yeah, it is certainly the bilateral approaches will certainly help, because climate change induced issues are not just sorry, it's not just very simple, because it has an international dimension. So that's one thing, and we need to have that responsibility. And on the other hand, I think we need to come up, we need the support, particularly the smaller countries and vulnerable nations. We need the support for policy development and policy implementation. And that's one area I feel that the country can be helped. Say, for instance, now, in terms of models, we need to have, say, policy models, implementation models, so that we can convince the governments in order to, at least then we have certain examples so that it can be implemented. Among them, I would say that in my experience, I know some of the interventions that the international communities have supported in implementing. It's short term and also very sparsely supported, very financially supported. Then what happens is that when a disaster comes, that whole thing collapses, because there's not enough sustainability and not enough rootedness. So therefore, I think we need to consider that whatever the support that comes from bilateral sources, it needs to have long-term perspective, and sustainability needs to be ensured. Because when you're talking about particularly the community resilience, it doesn't come in a jiffy. It needs to be properly built in, and that the communities are empowered to maintain them. So that's one of it. And secondly, I think we also require capacity building of the health workforce, because sometimes, particularly to do with the whole climate change issues, I don't think that there is sufficient knowledge base of the health workforce. So I think that needs to be, I think from the previous speakers, I just heard that, I mean, we learned that there are there are things in, the models are in place where they can be helped. So countries like Sri Lanka will definitely will benefit from such capacity building support. Yeah, I think that's from my side.
Thanks, Annie. That's a really good insight into Sri Lanka and the situation there. And William, can I ask you to give us an overview from your point of view in Malawi?
Thank you so much. From my point of view, I feel like such arrangements will be very beneficial and helpful. However, I feel like countries in low and middle income countries should also take responsibility to ensure that they offer enough motivation for healthcare workers to remain in our countries. For example, in our setting, what we are looking at is not necessarily an increased pay or increased salary. We are mainly a young generation on average of healthcare workers. What we need is a clear career progression path in our country, like in our health sector, where it is clear to say that, okay, you move from this level to this level, and where we have a platform where we can practice the skills that we have learned in the country or elsewhere, so that we can benefit the citizens that are lacking these services in our country. So these bilateral relationships will be very beneficial, but also governments should take deliberate efforts to motivate and retain the workforce that it has trained in the country and outside, considering that as healthcare workers and as with most professionals nowadays, we are global citizens. So we cannot be confined and limited to our setting when we see that there are not opportunities to make the most of our abilities. Thank you.
Thanks, William. I think a lot of people will kind of resonate with some of the things that you've just said there. Colin, over to you. What could I get your perspective on this?
So there are two models that some of our legislators are looking at. One that is presently being practiced and works reasonably well of exchange. So we partner with centers in Canada and in the US to help with the training of some of our specialist nurses, intensive care nurses, NICU nurses, with the understanding that they will spend a couple of years there and then come back with their skills. And also there is a plan to approach persons by saying, look, our nurses are going to leave, help us in terms of financing their training locally. They will give us a couple of years of service and then they can come to you after. So those are two models that are being looked at. At least that would help us with capacity for a period of time, and perhaps things will improve. That's something that's being looked at.
Okay, thanks, Colin. I think there's some very interesting points coming up here that we probably need to unpick a bit further, like moving forward, but we've only got a few minutes left. So I just want to move over to Laura and just ask if she's got anything to add to these comments, and then we'll move on to the final question just very quickly.
Hi, just picking up on the last comment, I think it's very important for the mutual exchange of knowledge to help either smaller countries, but also help ourselves. And we've done that with the St. Vincent's and Grenadines pathway. We've transferred from ethical recruitment due to depleted workforces to a mutual exchange of knowledge, and a continuation in the virtual platforms of the global healthcare now that we're doing is absolutely facilitating with that. And we're absolutely seeing the benefits from both fronts actually now.
That's great to hear.
Yeah.
It's really good to hear kind of some of these case studies coming out. So just quickly, the last question, and I just wanted to touch on the strengthening health emergency capabilities element of the forum that Dr. Nirmal started talking about earlier. And William, just over to you to talk a bit about the Cyclone Freddy in Malawi. And can you tell us about some of the challenges that you were faced with and how you responded to that?
Thank you once again. So I think the main challenge was that we were not prepared as a country for sure, and as a society even more, to handle a disaster of that magnitude and in multiple districts, because it was over 13 districts in Malawi. The other issue was communication lines were almost down. We couldn't reach contact points on the ground, and we couldn't even get resources to them. So communication and road network was destroyed in the process, including health facilities, among other key important infrastructure. Another challenge was there wasn't that needs assessment. It was hard to do a needs assessment because it was ongoing. The destruction was ongoing in nature. It spanned over 2 weeks or thereabout. So it was just from one disaster to another. So it was an on destruction. And also there was little coordination at the start. It started with just individuals mobilizing themselves and reaching out to the people that they could reach out to based on the intel shared on social media by those that still had their phones in the affected areas and could just share a location and maybe a video of the situation on the ground. As such, there were no or little coordination efforts at the start in the response that was mounted by different stakeholders. So what we did mainly as FASO, we just had a plan and we implemented the plan in 3 phases. We prioritized relief items and water and sanitation and disease prevention in the camps and affected areas like sanitary pads, water purification materials, and first aid preventive materials, things like those, and also care and treatment. We had to support the camps with supplies upon the needs assessment by either the responsible pharmacists for that district or other partners that were present on the ground. We also had to support our main referral hospital in the southern region with emergency care supplies, which they were running low, like adrenaline, because they were facing so many trauma patients as well. And we also had to mobilize our people as volunteers, and we presented them to the government officials and other partners that we are targeting the areas for interventions in that way, so that they can have a pool of expertise in the pharmaceutical field to choose from, ranging from supply chain, quantification of needs, procurement, and also actual dispensing of medications. Some were picked, some were not picked, depending on resources. So in the end, I think we learned that as countries or as authorities, sometimes we are not well prepared. If there is a coordination plan or a response plan is not shared with other players or other partners already beforehand. So I feel like having a plan is important, and having the plan shared is important. Having a recovery plan is also important to prevent such occurrences in the future. As we are talking, we will experience. Yeah, thank you.
Sorry, we're out of time now, but those are really interesting points, and I know, Colin and Annie, that you've probably had similar experiences, and sorry we're out of time. We have time to discuss that here, but just wanted to ask Dr. Nirmal if just for one closing remark, just a couple of lines in terms of, response to what William said about the cyclone and preparedness, and what would you recommend in terms of the framework that you've shared? How can countries really use that to sort of help them be ready for things that may come in the future?
Thank you, Victoria, and thank you, William. That's a good example. And I just want to start with by saying that we only remember preparedness when there is an emergency. And I think this is the big challenge. That's why we need to break the cycle of panic and forget. During COVID-19, we all talk about preparedness investment. COVID-19 is over. Now we all are in a crisis of mobilization of funding for preparedness. And similarly, that also applies to other forms of disaster. As part of the preparedness, I think, and as quite often I say that when we're responding to the events, we are also doing the preparedness also. So we need to capitalize that as well. And the BSL lab that countries developed in response to H1N1 pandemic influenza in 2009, look at how useful it was for detecting COVID-19 in many, many countries. So we need to build up on that also. From our side, what I think is the document that really provides the the guidance for countries to use to develop their preparedness, readiness, response plan. And because most often we build our capacities based on the indicators or based on the evaluation tools, and indicator doesn't bring all the actions that are required. So this document, which aligns with the indicators, but there are a list of actions in order to achieve that attributes of the indicator we need to do before and after actions also. So it has those comprehensive set of actions that country can use it. And with this expansion with the DRR, basically I can say that it's all hazard benchmark, the actions that countries can use also. And not to, because this is a global tool, but I would like to highlight that it doesn't fit for all purpose. That's why we always need to contextualize when you are using this document based on your local risk and hazard and vulnerabilities, because we cannot have a individual actions for each country, but we need to contextualize, and the locals, countries, people from the country, they know how to use, they know their situation better than the people coming from outside.
Okay, thank
Just
you.
one, just a one point. I think it's I'm reading a chat, and especially on the workforce related. I just want to touch upon one thing as we move forward, because of a crisis events, we are just seeing the decreasing number of the healthcare workers. So I think we need to be smart, and we need to develop the capabilities in order to not only task shifting but also strengthening the skill sets. It's a one person should be able to do another thing, and this is where the training comes. And we are rolling out one online training very soon, which will bridge the epidemiology, emergency side, and the health system side, because we need a cadre who can talk to epidemiology and health system, because the trainer, the public health workers right now, they are thinking in silos. So in 10 years time, we want public health cadre who understand that health system and epidemiology or outbreak emergency is part of the overall health system. Over to you, Victoria.
Thank you so much, Dr. Kandil. That's really insightful, and we can see those links there between the workforce and emergency capability building as well. So thank you. So I'm going to wrap up now and say thank you to my panel. Really great discussions. Wish we could go on for longer, but I'm going to hand over to David now, who's going to run us through the recommendations. Thank you, David.
Hello, Vicky, and I hope you can hear me.
You can.
Great. Well, thank you. I'm speaking from my car. I've been driving 100 kilometers while I've been listening to the interesting conversations, the wonders of technology. It never broke once, so it's been really good. If we could see the slides, I would just very quickly talk you through recommendations which are coming out. We have tested these recommendations in a survey. And you can see there we've had responses from several countries around the Commonwealth, a rough balance of gender, age group, interestingly, more younger people than older people. And we've had a distribution of the sectors, different groups contributing. But this is not a scientific survey, but it was a really helpful survey to inform the recommendation. So if we go on to the first recommendation, that is addressing the effects of climate change. We've been talking about that, we've heard about it. Here is a recommendation. These recommendations go to the ministers' meeting in Geneva in the wings of the WHO meeting in May, and the Commonwealth Advisory Committee on Health. I'm a member of that, as is Vajira, and we will also be discussing these. So the first one is a focus on the importance of climate change and health. The second recommendation picks up on things which we have been seeing in the last comments from WHO, recommending that the Commonwealth works between member states and with the Commonwealth Secretariat and civil society to strengthen the health emergency capacities. And we've heard about the real importance of doing that. It's no good waiting until a disaster happens. You have to be ready. All governments say they are preparing, but we saw in the pandemic but that doesn't always happen. So it's really important to prepare. The third recommendation brings up the workforce issues and is talking about the crisis in healthcare, which was picked up on from WHO. We know that there is a crisis within countries and between countries, and it's therefore really important that we have in recommendation 3 resilient healthcare systems that are able to address the complex needs of the workforce and to support health across the whole life course. And that's really important. Going through these very quickly now, recommendation 4 is about bringing together the younger and older generations. We've seen a huge loss of knowledge and expertise because people have been burnt out or have left the workforce, and we see enthusiastic people coming in who are trained but do not have the opportunity to develop their skills, as we have seen. So working together is important, and working with healthy communities, working across generations is really important for resilience within communities, as also within the workforce. Recommendation 5 talks about the sustainable availability and employment of healthcare workers and the ethical recruitment. And we heard about ways of doing that. The Commonwealth 20 years ago did have agreement about ethical recruitment, and we believe that they should be revisited. This is a very serious emerging problem that is being discussed all across the world, different aspects of it, but as the workforce shrinks and demand increases, there is a real need to focus on this, and there are real risks for vulnerable communities particularly, whilst also preserving the right of individual professionals to develop their skills, as William was saying, in Malawi, and to develop those and develop ways of providing service. Which leads us to the 6th recommendation, and this acknowledges the fact that there is increasing violence towards healthcare workers across the world, and that's seen in the frustration of the public who are seeking help, which isn't always available. And so it's really important to have a resilient health workforce and to recognize that those threats to the workforce are real and need a response. And I should say, as I'm finishing, that when we talk about the healthcare workforce, we're talking also about well-being, and that includes the social care workforce. I'm from the Commonwealth Organisation for Social Work, and it's really important to include the linkages between health and social care. We use different words for that in different countries. So, Vajira, those are the recommendations. We'll reflect on the feedback from this webinar and see whether we need to tweak those a little, but there was overwhelming endorsement of those recommendations from our survey, and I think from the comments in this webinar, that gives us confidence as we take those back to ministers. Vajira, thanks to you.
Thank you, David. Thank you for wrapping up the recommendations. So participants, you can see that the recommendations had overwhelming support from all of you who took the survey. We had nearly 100 of you responding to the survey, and the participants who responded came from across the Commonwealth. So as usual, what are our next steps? The next steps would be that we will take these recommendations to the Commonwealth Advisory Committee on Health meeting, which is happening in a couple of weeks' time. And then from there to the Commonwealth Health Ministers who meet in Geneva at the end of May. So at this point, I'd like to acknowledge the presence today in the webinar of the entire health team at the Commonwealth Secretariat. Lane Robinson, Janet Mugambe, and Emily Gilmore, all of you. They are a very important part of the work that we do. They are the people to whom we take our recommendations to, and we look forward to having that conversation in a couple of weeks' time in London at the Commonwealth Advisory Committee on Health meeting, where the civil society is represented by us. And with those words, let me thank all our speakers and panelists for being with us today. I was so grateful for you for having accepted our invitation and spending your valuable time with us. I'd like to thank all the participants for participating today, because it's your participation which really truly added color to this forum, which we have annually. And it is the forum where we, all of us come together, and your comments, both in the survey as well as in the chat today, will be captured by us when we make the final report, and all important points that you have made will be captured and incorporated in the survey, in the survey report and the report of the forum that we will be presenting to the Commonwealth Advisory Committee on Health. So with those words, let me thank all of you for your participation today once again, and wish you all the very best. And we will be sharing the report of the forum on our website. All the recordings from today will also be on the website. Do continue to engage the Commonwealth Health Professions and Partners Alliance, and we look forward to seeing you at our future fora. Thank you very much.